All right, thank you everyone for coming to the Monash IVF Women's Health Week panel. We're just going to give it a few minutes to allow everyone to log on and connect. So we'll start in about 2 minutes time. So thank you. And I can see we've got numbers ticking up, which is amazing for a Tuesday night. All right. So we might get started, obviously, as people join. That's absolutely fine. You can join at any time, but we'll kick it off because we have an amazing panel with us tonight that I'm really excited to introduce you to. So good evening, everyone, and welcome to tonight's Women's Health Week panel from Monash IVF. And I'd just like to start with an acknowledgement of country. So in the spirit of reconciliation, Monash IVF Group acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander people who are joining us today. And I just want to make a quick disclaimer about this presentation. We do our best to be affirming, but we just want to mention that in this webinar, it might include some gendered language or medical terms. And we know that not everyone identifies with these terms and that people may use different terms to describe themselves or their bodies. And we're really proud at Monash to support patients of all genders and sexualities. And we want to reiterate to everyone that everyone is welcome in our clinic. The information we provide in this webinar is really general in nature and it doesn't replace the personal advice from medical professionals. So just as a quick introduction, my name is Deirdre Zander-Fox. I'm the Chief Scientific Officer for Monash IVF Group, and I've worked in the field of assisted reproduction for more than 20 years. And I really love this field because the science that we get to practice every day directly translates into better outcomes for our patients. And that is something I really find rewarding. The science of IVF is just amazing. So in my role at Monash IVF, I oversee science and also research. And I also have some positions at universities where I do research collaboration. So doing both sides of clinical and research is something I'm really passionate about. So it's really great and I'm quite honoured to be here tonight as your host and MC, and really proud to be hosting all of our amazing doctors that we have that I'll introduce you to soon. I just want to talk to you a little bit about Monash IVF. So here at Monash IVF, we're really committed to empowering the next generation of parents on their journey to parenthood, no matter who you are. And we're here at all stages for people in their fertility journey, and we're really proud to support our patients of all genders, all sexualities on their pathway to parenthood. And we're really passionate about the care and support that we provide our patients that we've been doing for over the last 50 years. We provide world-leading science and medical services, and we have clinics across a huge proportion of Australia. So we're in Victoria, we're in New South Wales, Western Australia, Queensland, and then we also have our sister clinics, Repromed, in the Northern Territory and South Australia. So there's lots of sites that you can see on this map, all of our full service clinics, all of our consulting locations, which there are a huge number, as well as our day hospitals and diagnostic sites. At Monash IVF, we offer a really comprehensive range of fertility services. I'm not going to go through all of them, but you can see them all there listed for you. And we really do provide comprehensive reproductive care. And we offer everything from just basic fertility testing, just to get you some guidance in that space, all the way through to IUI, intrauterine insemination, and then also IVF and ICSI technology. And we can also support a variety of donor treatment for a wide variety of family dynamics. So I'm just going to take you through a little bit of the agenda, just me and my introduction, and then we're going to be moving to a Q&A with some of our amazing fertility specialists and women's health experts from across the Monash IVF group. So we're going to start a live Q&A soon with our 4 amazing fertility specialists you can see listed here. We have Dr. Prue Johnstone, who's the clinical director of our clinic in Geelong, Victoria. Dr. Jenny Cook, who's the clinical director of our beautiful Bondi Junction site in New South Wales. Dr. Fiona Langdon, fertility specialist and obs and gynaecologist, who is coming across to us from WA, and also Liz Jackson, who is a fertility specialist and gynaecologist, beaming into us from sunny Cairns up in Queensland. So we're going to start our live Q&A session really soon. It's just a reminder, if you could submit your questions via the Q&A button at the bottom of your screen. We will do our best to get to as many of those as possible, but it really does depend on the number that come through, what we were able to get to tonight. But I'd like to introduce you a little bit more to our panellists who have dialed in. I mentioned them before, but I'd like to give you some insight into who they are specifically. So this is Dr. Jenny Cook. She is a highly skilled fertility specialist, advanced laparoscopic surgeon and gynaecologist with 25 years experience in this space. She has a deep passion for what she does, and Jenny's special interests lie in the field of fertility treatment, endometriosis, fibroids and hysteroscopic surgery. She's a highly regarded expert in her field, and Jenny consults from Monash IVF Bondi Junction, where she's the clinical director. She is supportive and compassionate, guides her patients to make informed choices, and her collaborative approach is grounded in a focus on listening and recognising that every person's story and path to parenthood is completely unique and important. So welcome, Jenny. Thanks for joining us tonight. Our next fertility specialist is Dr. Prue Johnstone, who is a gynaecologist and fertility specialist with over 15 years experience in reproductive medicine. And she's based out in Geelong, Victoria, where she was born and raised. And she's really passionate about providing comprehensive fertility care for her local community and surrounding region. So she's the director of Monash IVF Geelong, and she also has a public appointment at the University Hospital in Geelong and has a special interest in infertility, PCOS, recurrent miscarriage, and also advanced gynae surgery. Prue combines her clinical expertise with a compassionate, personalised approach to patient care. So thanks so much for joining us tonight, Prue. We're also lucky enough to have Dr. Fiona Langdon as well joining from Western Australia. Dr. Fiona Langdon is a fertility specialist and obstetrician gynaecologist with extensive experience in both fertility medicine and also high-risk obstetrics. She trained at King Edward Memorial Hospital in Western Australia, where she was awarded the gold medal for her RANZCOG examinations and was named Trainee of the Year. She's passionate about providing holistic patient-centred care and has a special interest in supporting women with complex medical conditions through their fertility journey and pregnancies. She has founded the first privately run early pregnancy clinic in WA, supporting women through their first 16 weeks of pregnancy, offering regular reviews and support during that time that can often be really stressful for patients. She's based in Perth, as I mentioned, and she feels privileged to support women and families through some of the most exciting and emotional times of their lives. So welcome, Fiona. Thanks for joining us. And then finally, I have Dr. Liz Jackson coming from Cairns. So Liz Jackson is a gynaecologist and fertility specialist with Monash IVF in Cairns. She completed her medical degree at Monash University in Melbourne before undertaking specialist training in obstetrics and gynaecology, followed by a master's in reproductive medicine and endocrinology, and also is trained in minimally invasive surgery. Liz was also the first robotically certified operating gynaecologist in North Queensland. She has a broad practice covering fertility care, menstrual and pelvic health, endometriosis, and also advanced gynaecological surgery. And she's known for her down-to-earth approach and personalised care, and is passionate about providing women with honest, evidence-based support across all stages of their reproductive health journey. So thanks for joining us tonight, Liz. So this is our amazing lineup of our fertility specialists from Monash IVF. Hopefully you're as excited to hear from them as I am. So it's time for the Q&A portion of this evening. We're not going to be doing any complicated slideshows or anything. It's really just a forum for people to ask what questions they've got burning. No question is too silly, I'm sure. We've had some questions sort of come through earlier, and we'll try and do our best, as I said, to get to them all. But if we don't, you can always reach out to us later via, we've got a QR code at the end that you can book a nurse chat as well. So I'm going to click into the Q&A document so I can start them. And I think everyone's on speaker and we can hear everyone. Amazing. So welcome everyone. Thanks for coming. I'm going to start throw a question. I'm just going to throw it to a couple of you that have come through, and then maybe a few of them will be bit more of a dialogue and discussion between everyone. But I'm going to start with one for Dr. Jenny Cook, if that's okay. We've had one come through that says many people normalise pelvic pain as just bad periods. How can someone tell the difference between typical period pain and something that could be more serious like endometriosis?
So that's an excellent question. I think for so long, women have been ignored, and I think many women, pain often can start as teenagers, and these women just learn to normalise their pain and they're told to just get on with it. My personal view would be that there's people here to help and listen, and I'm one of those. If the pain is too much, if it's impacting your day, waking you up at night, then it's a problem. It's not normal. That's actually what I would say. And women will often say, maybe there's nothing wrong. I don't know if I should have come in. If the pain is enough for you to go to your GP, if it's enough for you to then come in and see me, then it's a problem. It's not normal.
And I can see a lot of everyone is nodding at that one from what I can see. Was there anything else anyone wanted to highlight on that, or everyone's just agreeing that's basically it? Yeah.
I would also say if it impacts on your life. So, you're needing to take time off work, or you're missing school, or, if you can quantify it in how it impacts your life, that's not normal.
Yeah. Excellent. Okay. I have one here who has said, it's for Dr. Liz Jackson. Why is it important for regional patients to have access to fertility care locally, and does that continuity of care benefit patients?
Yeah, thanks for having me tonight, Deirdre. Yeah, it's very important for patients to be able to access specialist care in regional areas where there are women. There are a vast array of women's health challenges, and the closer we can deliver that care to home, the more the community benefits. There's less time away from family, from friends, from work. It will lessen the financial impact of reproductive health treatments as well if we're able to stay here locally in our community. And we're quite lucky that in Cairns, as a satellite clinic, we have flying in for our treatments, 3 embryologists at least for our cycle sessions. And so being able to access that additionally means that with a local regional specialist, or when you can have your treatment close to home, that you're able to also have the continuity once you fall pregnant, or if there are other issues following your treatment as well, that you can receive that care and stay within the community. And hopefully, with a pregnancy, we can help guide you through, particularly that really challenging first trimester.
Did you want to comment on that, Prue, given I know Geelong's not as regional, but still is regional?
We still call it a big country town here, really. Yeah, look, I completely agree. And I think Monash is fantastic at acknowledging, and certainly in Victoria, we have satellite clinics that service the Gippsland, Bendigo, Mildura, Albury-Wodonga and also Geelong. We're very lucky in Geelong that we sort of, even though we're in a regional service, we do have a full-time clinic down here. And you definitely see that, you know, it improves the journey for patients. Not having to travel means that they don't have to take as much time off work. And anything that you can do to improve the burden of what they're going through, you know, sometimes people don't want to tell their workplace what they're doing, which is completely reasonable. And we can have appointments very early in the morning or after hours, and so that's really helpful, I think, for patients.
Excellent. All right, so for anyone who's just joined, if you have any questions, if you just pop it through the Q&A button at the bottom of your screen, they'll then feed it through onto the list that we're compiling. I have one here. I'm going to pass it to Fiona, but maybe it's a bit more for the broader panel. It's about AMH, and should you get your AMH checked? When is it useful? What are your thoughts on that topic?
Right, so great question and really controversial, I
Yes.
think. So the first thing I would say is if you are going to have your AMH checked, so usually you're doing that through a GP initially, you need to have a plan about what you're going to do with that result. So there's no point having that done if you're not prepared to interpret it and act on it or process it, because it can be extremely stressful to get an AMH level back and find that it's really low. So for those who don't know, which, you know, kind of it's a acronym that we use, AMH is measuring your anti-Müllerian hormone, which is a hormone that is produced from your very small follicles in your ovary, which are growing up each month and do kind of give us an idea of what your ovarian reserve is. What it doesn't tell us is how well you will spontaneously conceive. So it's telling us maybe how well you will respond to IVF, or possibly, if it's very, very low, are you close to menopause, or is your ovarian reserve much lower than the average woman of your age? So it definitely doesn't give us the whole story of your fertility. And so it's a test that just done on its own is very difficult to interpret in terms of your fertility. So if you are going to get it done, it should probably be done in a group of other investigations, and it needs to be done in a way that you will take that result and what will you do with it? Because at the same time, it's not, if it's a good result or above average for your age, it's not necessarily going to tell you you're able to get pregnant easily. So it can give you a false sense of security really as well. So it should be done in a situation where you're going to be able to interpret the result and also take it kind of with a grain of salt. I think is important.
Yeah, it is a really controversial topic at the moment. Was there anything else anyone wanted to add on to that one, or Jenny?
I would always get an ultrasound done to look at the number of follicles in the ovaries, and I'd match them up. And if the antral follicle count and the AMH are about the same, they're probably both accurate. But I think what Dr. Fiona Langdon is saying is that it's not, the AMH is not the new black of fertility. You have to take that test in the context of other things going on. I always say everything paints a picture, and your age is the biggest determinant of age, fertility. Young women will get pregnant with a low AMH. Older women probably won't, or will have more problems.
We've had one come through. I'm going to throw it to you, Jenny. I'm a 38-year-old female. I don't drink or smoke. I'd like to have children, but I don't have a partner yet. Can I freeze my eggs at this age with the intention to get pregnant later?
Yes, you can. So egg freezing is a really viable option for women to preserve fertility. The technology of egg freezing has improved dramatically in the last 8 to 10 years, and we really do see babies being born from eggs that have been frozen. It's amazing technology, but it's not a guarantee of pregnancy. It's a good insurance policy. It's not a guarantee of pregnancy, is what I would say. I would talk to that 38-year-old woman. I'd take a good history. I'd look for anything that might be a barrier for her to conceive. Is there any suggestion of endometriosis? Does she have polycystic ovaries? Does she have fibroids? Is there anything else that's going to be a problem that she needs to know about? And I would also plant the idea, I would say to her, would you ever think about doing it by yourself? What are you going to do with these eggs? In other words, if your aim at the end of the day is to have a baby, have a time frame for that. And I generally encourage women to use their frozen eggs before they turn 40, just so that if those eggs don't work, they've still got the option of getting pregnant potentially with their own fresh eggs, if you like. That's a long-winded answer, isn't it?
No, that's great. Was there anything else anyone wanted to add on to that one? Everyone's same or?
The other thing is with regards to cryopreservation of fertility, there is sometimes potentially also a role to consider creation of embryos using, for example, donor sperm of a known or an unknown donor. Embryos do carry that slightly higher probability of success compared to just oocytes alone. So it's included in the conversation with fertility specialists that, yes, cryopreservation of just eggs, but also consideration for embryos as well.
Wonderful.
Okay,
Thanks, guys.
Can I just say one thing?
Go.
That's absolutely correct, that embryos do have the edge in terms of the pregnancy rate. But if it's a single woman, you can be very thorough and talk about donor sperm, but she's doing it potentially if she meets someone later on. And if she's got embryos, she's never going to use those embryos. She's probably not going to use those embryos in the context of a relationship. That's the only thing I would say. As a modality to preserve fertility, it's not as useful. That's all for a single woman, but obviously different if she's in a relationship. But this woman's a single woman.
Yes.
She's a 38-year single woman.
Did she say? Oh, yes, she said she doesn't have a partner. Yes, yes, right, yeah, yeah. This is a specific question. I might throw it to Prue. I'm going to read it because it's specific for this person personally. Recent AMH and progesterone levels tested: high AMH 52.4, progesterone 73. Are these results indicative of PCOS or CIS, or should I have further investigation?
So with regards to the AMH, it doesn't matter when an AMH is done within a cycle. It should remain stable through your cycle. And so you don't need to do that at a specific time. You do need to be very cautious of doing an AMH if you are on the combined oral contraceptive pill or another form of contraception that suppresses your ovaries, and that's the way that some contraceptives work. With regards to a progesterone, that's a bit of a tricky situation in the sense that if you see a very high progesterone, it probably means that you have ovulated. So it sort of depends on when in the cycle that was done and what your normal cycle is. So if you have a regular cycle or an irregular cycle, sort of determines what, I guess, how we're going to use that information. It sort of really depends on why why this patient's had these tests done. And I guess they probably don't really match up in the sense that often if with a very high ovarian reserve, you're questioning whether this patient has polycystic ovary syndrome or certainly a very high ovarian reserve for age. But a high progesterone also probably suggests that her cycle, at least some of her cycles, are ovulatory. So it really probably depends on whether she's actively trying for pregnancy or whether she's wanting sort of some fertility reassurance in terms of what sort of advice we would give.
Perfect.
Does that answer the question? I think
it was also, do I think you need further, does she need further investigation? And like you sort of said, possibly it depends on.
Look, it depends. I mean, PCOS is interesting in the sense that obviously, it is important to, there are reasons to diagnose true polycystic ovary syndrome. Saying that, I mean, PCOS has different implications for different times in your life. So if you're young and you've got problems with acne and hair growth and issues like that, then, to be going on the pill or something like that would be of benefit for those symptoms. if you are actively trying for pregnancy and you don't have a cycle, then we would be treating your cycle. So we're really kind of looking at you at that sort of age of that you're presenting and saying, look, what is the current concern and how do we help that? And there are sometimes, you know, long-term medical implications for PCOS. So, you know, if it goes hand in hand with metabolic issues such as, you know, a higher risk of, you know, diabetes, cardiovascular risk factors, problems with difficulty losing weight or an elevated BMI, then those need to be addressed, and they are kind of general women's health issues, not just related to sort of the gynecological side of things.
Yeah. This one I might just pose to everyone. Different states can have different legislation potentially. People might get confused by that. But is there an age cutoff for patients at Monash? So maybe we'll go round the grounds, or we'll start with Fiona and then.
So,
yeah.
So I'm based in WA, and so the kind of guidance we have at our clinic is that for assisting women to get pregnant, we can do that until your 53rd birthday, okay? But in terms of doing an IVF cycle using your own eggs, so when we talk about, you know, doing any form of treatment, we might be talking about donor eggs, donor embryos, not necessarily doing an IVF cycle, but doing other forms of treatment. But for an IVF cycle using a woman's own eggs, our clinic cutoff in WA is your 45th birthday. But in saying that, we do have an opening that as a clinical team, if there is a patient we feel who does justify going through treatment, we as a complete group of clinicians, all of us in the group will sit down and have a meeting, and if all of us deem it appropriate, we will do an IVF cycle on a woman using her own eggs after her 45th birthday. So that's kind of so we do have a 45 cutoff, but it isn't in consultation, it's not, but then any treatment is the 53rd birthday.
Jenny? Is that the same Sydney?
So, no. So you can, in New South Wales, or at least at our clinic, you can be seen for treatment to achieve a pregnancy using, you know, donor eggs, donor embryos up until your 53rd birthday, and using your own fresh eggs is your 46th birthday. And we also have a, you know, committee that would look at special cases, but I think more and more we're saying we have these guidelines for a reason. And look, for someone after the age of 44, I would say you have to have a very guarded prognosis. And after 46, like, they're so rare. They're so rare. More and more we've been saying we've got the guidelines for a reason, we should stick to them. But we do assess any request for treatment using a woman's own eggs after 46.
Liz in Queensland?
We pair with Fiona with the age cutoff, and as Jenny said, things are taken as individually, you know, when needed. The situations can go to, again, a panel of experts. But as a also practicing generalist, there is real concern with advanced maternal age and pregnancy risk as well, which just needs to be included as part of the discussion. So pregnancy not being the end goal, actually health and well-being as well. So for that, you know, really making sure that there's a comprehensive review of a person's medical status. We want to make sure there's no underlying medical conditions which are more likely sometimes as we get a little bit older. That can include problems particularly around blood pressure and diabetes. So incorporation of care includes at a certain point as well physicians to conduct an expert assessment of wellbeing and pregnancy candidacy.
Yeah. And Prue for Victoria?
It sounds like we're very similar to New South Wales. So we have the same cutoffs in terms of 46th birthday for own eggs and 53rd birthday for if they're using donor or embryos have already been created, or that embryos need to be created before 53rd birthday. And I completely agree with Jenny in the sense that, you know, you do need to think about, you know, providing ethical treatment. So when success rates become so low, getting into those middle 40 years using own eggs, that you're really wanting to, very carefully counsel a patient or a couple about improved success rates with using donor egg.
Beautiful. Okay, I've just lost my list of questions, so please excuse me while I find them back up again.
Deirdre, while you're doing that, I'll just
You do
add
that.
on.
You fill the gap while I find my questions.
When we talk about, like for that woman who's 46 or 47, say in New South Wales, also, taking into account the medical risk, I think psychologically it can be really healing for them to know that they have tried everything. And that kind of one last go for a lot of couples or women can be that kind of closure they needed to say, do you know what, I'm now ready to move on to donor eggs, or I'm now ready to close this chapter of my life if it's not successful. But for a lot of women, they really feel stopping before they feel ready can, for the rest, a very long time after that, have a significant psychological burden. And I think that's where we really can say, in individualized cases, this, taking into account if they're well counseled about the risks, that it can be helpful.
Excellent. I've got one here for Jenny. With the new changes this year to the national guidelines for miscarriage care, is it true that recurrent miscarriage can now be acknowledged and monitored after 2 miscarriages in a row? What does that mean, and how does this change support and/or monitoring for patients who are suffering from this?
So I would say many practitioners, myself included, we've probably investigated after 2 in any case. If a woman comes in and says, I've had 1 miscarriage and it was really traumatic and I want to be investigated, I would say to her the most common reason for one first trimester miscarriage is just a spontaneous mutation. But if she wants further investigations, you would investigate after 1. So the guidelines are 2, I think, and traditionally we've always done 3. I think we need to listen to what the woman's saying. Did you want me to go through a list of investigations, or you're really just talking about a time frame?
I think it was just sort of asking about how the changing guidelines are changing the support and monitoring for patients. So I don't know if it changes anything from a...
No, I don't. I mean, okay, they might be the black and white guidelines, but I'm prepared to say if a woman has come in and said, I've had 1, I would offer her support. If she says, what can we do to minimize the risk of that happening? You can talk to her about taking progesterone longer in the luteal phase. You do all the usual investigations, look at her thyroid, look for any reason in the uterus like an endometrial polyp or a submucosal fibroid, which like reversible causes. If she's got low ovarian reserve, that is likely to be associated with poorer egg quality, you can counsel her about that. Maybe she's ready to do IVF with genetic screening, and we know that if you transfer a euploid embryo, that's going to have a very significant reduction in the risk of miscarriage. Like, there are strategies, and I think you would always listen to the woman. If she wants to intervene earlier, I would be supportive of that.
Yeah, excellent. I'm getting a lot of nods on that, so that's awesome. Prue, I've got one for you regarding IVF, which offers a higher chance of success: egg retrieval followed immediately by embryo production with fresh eggs and sperm, followed by implantation of the fresh embryos, or is it the same if the eggs are frozen first and then embryo production is carried out several months later? So I think the question there is what is better for success, using everything fresh or freezing the eggs, or maybe even frozen transfer instead of fresh? Complex question.
I think it is a good question, and the reason, I think, when you are counselling someone about egg freezing, I completely agree that we shouldn't ever call it we shouldn't call it a guarantee, and I'm also very cautious about calling it an insurance policy, because the way I explain it is that that egg has still got so many hurdles to get through to get to a pregnancy. Whereas when you have an embryo frozen, that egg has already fertilized. It hasn't had to survive a thaw process, and it has been introduced to sperm, fertilized, and got to a blastocyst stage. And they are all very amazing scientific things that an egg needs to do to start to become the chances of a pregnancy. So it's not so much that, you know, we do see cycles with frozen eggs that do just as well as fresh eggs. We also unfortunately see, you know, egg thaws, you know, using frozen eggs where no embryos are produced. And I will unfortunately never know for that patient or that couple whether, you know, that it might have been a different outcome if those eggs were used fresh, because, you know, very occasionally you are doing an IVF cycle using fresh eggs and you don't get any embryos either. So it's a little bit hard to know, you know, retrospectively what is going to be the outcome. In terms of, you know, using fresh or frozen embryos, I think it's very, you know, I think we can all very sort of safely say that there is no real success rate difference in using a fresh or a frozen. And probably there is some potential benefit in using a frozen, you know, in putting an embryo back that has been frozen and thawed, and that's mainly because of the environment that you're putting that embryo into. So, you know, if you think that when we're putting a fresh embryo back in at the time of a stimulation, the main sort of you know, the main thing that we're wanting from that cycle is egg number you know, eggs to be retrieved to make embryos, and the benefit is that the lining thickens up, so you can time to put a fresh embryo back. But, you know, I guess there is a bit of a question about, is that a bit of an abnormal you know, environment for an embryo to be in? So I think there is enough data out there that says that you might get slightly better pregnancy outcomes with frozen embryos, and that's really, you know, it's still okay to do a fresh embryo transfer, but it's really reassuring for patients to know that that they can have a frozen embryo transfer, especially if they're, you know, feeling a bit unwell after the egg collection, or they're at risk of hyperstimulation if they've got a really high egg number, that they're still going to get a really good chance of success with a frozen transfer.
Excellent. Thanks, Prue. I've got one here that I'm going to kind of throw to the whole panel, because everyone's probably got something different that they really like to emphasize to their patients. What is your top, I guess, maybe you could go with 2 to 3, you know, main things from a health advice perspective that you advise women who are preparing for pregnancy to consider, either through natural conception or assisted reproductive technology? How do you best advise your patients to prepare physically and mentally for pregnancy? So maybe we'll whiz round and we'll start with Fiona. Go to you first.
So I would just say, from just a pure medical point of view, optimizing all your health conditions. So it's really worthwhile having a preconception appointment with your GP, and then liaising if you do have any specialists for, say, a chronic medical condition. So if you're diabetic, if you have been on weight loss injections, which a lot of patients are now, things like that, just being aware of any medications that you are on, or particularly any supplements or kind of over the counter or over the internet things that you're on, that just finding out whether or not they are safe in pregnancy, and then whether or not they also need a washout period. So a lot of medications will need a period that you should be off them before you do start conceiving. So I think having a good review of your medical conditions, if you have any medications that you're on, is really important.
Brilliant. I'll throw to you, Jenny.
Yes, I suppose just having a pre-pregnancy consultation with your GP or with a specialist is important. If there's something wrong, like if you've got a lot of pain, if you've got an irregular cycle and you don't know when you're ovulating, if you've got really heavy bleeding, see someone sooner rather than later. But that goes for the men as well. I think they're often the forgotten entity. I suppose this is Women's Health Week, but the men need to have a semen analysis. the women need to be on folate. That's basic. And I ask everyone, how much do they drink and do they smoke? And it's quite a surprising number of women that come in and say, I'm vaping and I can't get pregnant. And I say to them, the most important thing that I'm going to say to you today, the most important thing out of everything, all these tests I'm doing, everything, stop smoking. And I suppose that just comes into general health. Yep. Exercise a moderate amount, don't over exercise, don't under exercise, and weight range, in the normal weight range, we say BMI 20 to 25.
Brilliant. Liz, anything?
Yeah, I think that additionally, just with the GP check, just really going through some of the supplement use as well as vaccination status. So rubella and chickenpox historically were leading causes of blindness and deafness in babies at the time of birth. So just ensuring that your vaccinations are up to date in that regard, because where I live, there are occasional outbreaks, and we do see that. But supplement use, there are some really, really well-studied recommended supplements, particularly folate, iodine if needed. But also there is a bit of a big business around promising the world with some supplement use. And look, I'm from North Queensland. The phrase we would use sometimes is it just can make expensive urine. So you really do want to make sure that, if you are on a supplement, that first of all, if you're on a nutrient supplement, that you're deficient in that perhaps, and that would be linking back in with a GP to review. And if you're not certain, probably maybe hold back a little bit. But additionally, there is the need for mental and emotional preparation for fertility as well. So focusing on stress management, perhaps having a realistic expectation of a fertility journey, and also just maintaining relationship and support networks. So fertility journeys can sometimes take a while, and really making sure that you do continue to live life and not socially isolate during that experience. I think that it's important, that connectedness for overall health and wellbeing.
Anything from you, Prue, you'd like to add?
Yeah, I think most things have been said. Certainly one of the newer things that have come in around, that preconception counselling is genetic carrier screening, which I think is really important, especially if you are, potentially, I think, well, it's important for everyone. Anyone who's thinking about getting pregnant should be having at least the 3-gene test, which is checking for cystic fibrosis, spinal muscular atrophy, and Fragile X. And that's now a bulk billed free test that the government has subsidised. So that's fantastic. But there are options for more extensive genetic carrier screening as well that are more expensive, but do give you a lot of reassurance, and basically are testing both you and your partner and to make sure that you're not carriers of recessive genes that might cause a disease in a baby or a child. So, and I think most GPs should be aware, should know to offer that and be aware of that. And obviously, if anything does come up, then you can be referred to genetic counselling and a fertility specialist to discuss things like the option of making embryos and testing them before they go back. So there is something that we can do about that. Probably the only other thing I would say is just really kind of trusting and I think going back to mental health and making sure that you're doing everything you can to maintain a positive mindset and things. We know it's really, really difficult. Some people go down a real rabbit hole with alternative therapies and acupuncture and naturopathy and all those sort of things. And I guess the way that I explain to my patients is that, look, if you're enjoying it and if you find that it's giving you good stress relief and you are finding that it's improving your general well-being, absolutely, keep doing it. But if you're finding it very stressful, if you're finding it financially difficult, I don't believe you're doing yourself a disservice by not doing those things. So I just think that sometimes people feel like they're forced to do those sort of things, when you really just need to consider what your, you know, what your beliefs are, and how accessible things are. Obviously, you know, being from regional areas, sometimes those things are difficult. But yeah, certainly not feeling like you're not going to have success if you can't access those things, or you can't afford to access those things.
Brilliant. And thank you for that. Someone actually did ask about reproductive genetic carrier or reproductive carrier screening and the process and navigating it. So your advice is that GPs and obviously fertility specialists all understand that process and can help guide.
Absolutely. Yeah. So
Yeah.
and GPs should have, you know, certain providers. I mean, obviously, so Monash, there's great information on the Monash IVF website, and you can order tests, I believe.
Yeah. Yeah, I think so. Yeah.
On the website as well, and you get, you know, and also important to be using a provider that provides genetic counselling if an issue does come up. So you know, I think that you can be advocating for yourself to do that, but really you should be also having doctors around that can help navigate that for you.
Brilliant. So I just had someone asked a follow-up question because someone mentioned folate and iron. The question is, and I'll just maybe throw it out to the panel, whoever wants to jump in, are prenatal vitamins necessary, or is it only folate and iron?
It's actually only folate and iron.
Yeah.
Folate and iron,
Yeah.
and even iron if you aren't iron deficient, if you've got an adequate hemoglobin and an adequate dietary intake until you're pregnant, you don't need to supplement on that. Pregnancy will double your iron use, and breastfeeding will triple it. But when you're not pregnant, if you're not suffering heavy periods with a normal hemoglobin and iron, I think even just a folate. Would you agree, Jenny?
Yep, just folate. Maybe iodine.
Yeah.
Brilliant. Excellent. And there's another supplement question. So this one I'm going to throw out to anyone because I'm not familiar with it. Would you recommend myo-inositol in PCOS for PCOS patients? Myo-inositol. Anyone? I've not heard of that one. So
the dietitians actually will. I mean, there is some evidence that it can lower insulin resistance, but my personal feeling is if a woman is overweight and that is the major factor for her increased insulin resistance, she needs to work on diet and exercise. And if she wants to get pregnant, there are options to trigger ovulation. Like there's other options, but I can tell you there is some evidence that that agent does actually have a role.
brilliant.
I don't think there's any harm in using it. That's one. I guess that's always one thing that I always say to patients is that if they're on these crazy, you know, or they're on certain supplements, it's like, you know, it won't do harm. It's just a question about whether it's going to do much benefit. Some of those supplements do go hand in hand with things like metformin and things for treatment of PCOS also.
Yeah, I would say if there's something, if you're worried about insulin resistance, being on a medication that is going to be proven to improve your insulin resistance would be more helpful than that.
Yeah,
No, I would agree.
Such as metformin. Yeah,
it doesn't replace. It's an adjunct. It doesn't replace lifestyle changes and medical treatments.
Excellent. So we're getting a few follow-on ones. So I might just I'll stay on the supplement one because we're getting a few of those. This person is saying they find it really difficult to digest iron tablets and has, you know, gut impacts and constipation and things, even though they eat a lot of fiber. Is there any alternatives or different things that you guys recommend rather than the standard iron tablets?
There is chelated iron. So the particular, can I say the brand?
I think so.
It's called Fab Iron. It's chelated and it doesn't seem to have that same impact on the gut in terms of causing diarrhea or constipation or cramps. So that's how you take iron.
Yeah.
And additionally,
Excellent.
you can increase the absorption with vitamin C. So that's got evidence. So either orange and you reduce the iron absorption if you consume it concurrently with calcium. So the other thing with iron is, you know, you can sometimes just do it every other day if it's having a significant gut impact.
Fantastic.
or consider an infusion.
Yes.
Yeah. Excellent. So just going back to the genetic carrier screening thing, which I think Prue you raised, is genetic carrier screening still recommended even if you don't have a family history of genetic disorder?
Yes. So I always try and get people to go back to like year 9 science in their brain when I'm talking about this and remember how things are genetically inherited. And people look at me sort of, you know, and sort of say, how on earth would I remember that? Basically, if you have a genetic condition that is coming through the family, so one of your parents has it and you have it, it is probably almost certainly an autosomal dominant condition, and that means that if you have one abnormal gene, then you will have the disease. What we're actually worried about is having an autosomal recessive condition get passed on to a child. So we are all walking around with several mutations in our genetics, but because we have one normal gene working, that we do not have that disease. And what we worry about is if we meet someone and want to have a child with someone, or we're using a sperm donor that has a specific condition, that if our genetics comes together, we have a 1 in 4 chance of having a baby that is affected. And so, a lot of people say, well, I don't have a family history of cystic fibrosis, but we know that about 1 in 25 of the Caucasian population are a carrier. And so it's not that uncommon to think, that, you might meet someone who is also 1 in 25 and then have a 1 in 4 risk of having a serious, condition develop in your child. So it is something that doesn't really relate to your family history. So we would still recommend that be done.
Absolutely.
Yeah, I always quote to my patients, I've said that, so 95% of children born with cystic fibrosis in Australia have no family history of it. So although both their parents carry the gene, they've just no one else in that family tree has also had a child with someone else with a 1 in 4 chance. So absolutely, family history just doesn't come into recessive screening.
And those 3 were selected because 1 in 25 Australians is a carrier for one of those 3 conditions. So they've been very carefully selected, and for that reason.
Yeah. I might throw this one to you, Fiona. Do medications like Ozempic, and I think we talked about that before, it's a big topic at the moment, and maybe to anyone else, do medications like Ozempic have an impact on fertility?
So in health, we know when women, particularly women with a BMI of 30, so we talk about a BMI of 20 to 25 being ideal, but really we see a huge impact on fertility, both either spontaneous conception or success with fertility treatment once that BMI goes over 30. So once your BMI is in that obese range, your weight is having a significant impact on your chance of success. And so in that setting, where we want you to aim to possibly lose weight very effectively and very quickly, I think the new injections which are on the market are going to be helpful in being able to get your BMI down to a lower range, which may see you be more successful with your treatment. In saying that, there's very, very little safety data about their risks in pregnancy. And so at the moment, the recommendation is that you have around a 2-month washout period before trying to conceive. So it does mean that if you are trying for spontaneous conception, it may mean that you lose this weight, and then we know there's a big rebound while you're waiting for that washout period, and then perhaps waiting a number of months to try and conceive. So the jury's kind of still out on weighing up the benefits of the very significant weight loss you may see, because they are really successful weight loss treatments, but then will they, with the washout period and then also waiting to conceive after that, actually have a negative impact? And we're also not really sure what the impact it may have, particularly that kind of very, very rapid weight loss. Does that affect egg quality? Does that affect the endometrium lining and the environment with, that kind of perhaps quite significant protein malnutrition that women may experience with that significant weight loss with the either, say, so for gastric sleeves and things like that, where we saw very rapid weight loss with bariatric surgery, again, we recommend women wait 12 months after stabilizing their weight. So there's not a lot of evidence out there about what the effects will have on fertility, but we do know that weight does play a role. So we're watching this space really carefully, I think, to see what impact it can. And I mean, for some of my patients, I am recommending it. We have a GP in our clinic who's fabulous at talking through the risks and benefits and prescribing it for our patients. And so definitely I do have patients who are going down that pathway and looking at trying to lose weight to improve their fertility chances using that method.
Excellent. Anyone else want to comment on that? They're obviously such a big thing at the moment. I'm assuming patients are coming through on it for fertility treatment. Anyone else want to chime in? Well, you've covered it beautifully, Fiona. Perfect. I might throw this one to Jenny. What are the options of getting pregnant when you've got a new partner who's had a vasectomy?
How old is the woman?
Doesn't say. Sorry, she hasn't popped that one through, so yeah.
30s. Well, one option is if he had the procedure done within the last 10 years, he could have it reversed. But you would want to know that she stands a good chance to conceive naturally. So she needs to be, you'd be a bit, I'd want to see her in her 30s with good ovarian reserve, a regular cycle, and nothing else that's going to have a negative impact on her fertility. Tubes are open. Like no other reason for her to possibly need IVF. If he has the reversal, he then needs to know that it might not work. It might work and then the tubes might re-stenose and it fails. She might still need to go down the pathway of IVF. And of course, the second option is he could have a surgical sperm collection and the sperm could be frozen and then she could go through IVF. There you go. They're the options.
Yeah.
We mentioned vasectomy reversal.
Yeah, of course.
Jenny, yeah.
I said, but you would want to know that that woman stands a good chance of conceiving spontaneously, and you would want to tell him about the risks of it, the risks that it might not work or that it might work, and then the tubules fibrose and then later on it fails.
And obviously, if they do go down the path, there is IVF surgical sperm retrieval,
and then if they go down IVF surgical sperm,
true. Excellent.
Easier, something like that.
All right, I might throw this one to you, Liz. I'm 34 and I'm planning on getting pregnant soon. I currently enjoy about 120 ml of alcohol most nights, sometimes red wine, rice wine, or whiskey. Should I stop drinking completely while preparing for pregnancy, or is it safe to continue in moderation?
So I'd often say that preparing for pregnancy is a great time to review lifestyle habits. So with alcohol, the safest approach is to stop drinking alcohol before trying to conceive, but we don't have any specific amount that we know to be completely safe. But that being said, it's sometimes part of somebody's routine and it's okay to gradually make the changes and to get the support. But really what matters is just trying to move forward continually with those health style measures, because giving your baby the healthiest start in life is the most important. So, it's one of those things, you can take it slower, but definitely light consumption if trying to conceive. Preferably if you can stop, but again, it's important to continue to live your life whilst undergoing a fertility journey, because sometimes these things can take years. But just review your alcohol consumption with your GP to keep a bit of an eye on it if needed.
Yeah. And what about coffee, everyone? What is your recommendation to patients, both sides of both men and women? What is your recommendation for drinking coffee and its impact on fertility?
I say under 2.
I think 1 or 2 is fine.
1 or 2?
Yep.
Everyone's going with 1 or 2. Brilliant.
We're not terrible, not really mean. We're not like completely mean. You're allowed to have the coffee here.
You said no coffee, that would be just devastating.
And meanwhile, your doctor's sitting there with a cup of coffee in their hand.
Swirling it in front of you, which is just cruel.
Yeah, you got to stop that.
Absolutely cruel. All right, well, I'm just conscious of the time and we're getting a bit close to the end. So I'm just going to pick a last couple, and I'm so sorry for people who've sent them through and we haven't gotten to your questions. But this one I think is about the relationship you have with your fertility specialist and how important is it? What do you all think about people who see a fertility specialist and maybe it's not going so well? What would your recommendation be?
I'd love
Well, I
to.
say
Take
kind of.
Um,
We'll go to everybody. We'll go Prue first. We'll go to Prue first, and I'll get everyone to chime in on this one because it's a big one.
Look, I think that you absolutely need to have good rapport with your fertility specialist, and that's different for different people, and obviously, you know, some people like a more paternalistic kind of approach of, you know, being guided strongly about what they want, what they should be doing, and other people really want to be very involved in decision making, and it's really up to us as clinicians to kind of gauge that at you know, your initial appointment, but also to be kind of always giving you options, and then you and helping you make the decisions that you need to. Obviously, you know, it depends on where you are and whether you have other options. I think most fertility specialists do phone or telehealth reviews these days as well. So if you are feeling isolated in certain areas, that is sometimes an option. But yeah, I think it's super important, and I think it definitely helps take the, you know, the emotional load off you when you're trusting, you know, your fertility team.
Excellent. Fiona, I'll throw this one to you quickly as well.
Oh,
I'll go
I
round.
mean, you need to be able to have a rapport with them. You need to be able to not think any question is silly, not feel that they're going to feel offended by any question you ask about the treatment. You know, like, it needs to be a really open relationship. When couples or patients have been asked why they stopped fertility treatment, you know, it's not the financial burden, it's the psychological burden. You need someone going through this with you who is going to be able to support you, and you feel supported by, and have a relationship that you feel comfortable to ask anything, including the hard questions. You know, well, why did you make that decision for my treatment when it clearly didn't work? Or, you know, and as fertility specialists, you know, it's a science that isn't exact, and it's a treatment that often isn't successful. So, you know, we want to be able to explain to you why we made those decisions and why we thought that at the time was the best, you know, option for you. I mean, couples who go through this, and patients who go through fertility treatment, and patients who've gone through cancer treatment as well, say that the fertility journey is harder. So you need someone who's going to walk that with you, and who's going to be able to, you feel supported by. So 100%, if you are not feeling that, be open with your doctor, or feel really open about getting another opinion. And no fertility doctor should be upset if someone goes and gets another opinion. I think that's telling you that your patient's empowering themselves to get the right answers for them and feel, you know, that they are on their right journey.
Amazing. Jenny, anything to add?
I'm only I like to let the patient talk. Like, when I first meet them, I want to hear their story. I think I ask some questions to just direct in terms of what I want to know. But I want to listen to their story. And I think I always say to them, at the end of that, I'll say, well, these are the issues. These are the things that we need to think about why you might not be getting pregnant. We need to think about the time frame. And I make it so clear that we're making this decision together. But in many ways, I'm quietly trying to guide them with a decision. Like, if they've just been trying too long and they need to do IVF, or they need to do something else. So we think about the time frame, about when they might want to start, and then I also go through the options, whether it might be surgery, whether it might be, you know, IVF or ovulation induction or something. And I always stop and say, have you got anything else that you want to say or ask? I absolutely don't want you to ever walk out of this room and think, I don't understand what's going on. Like, I want you to have a clear understanding and feel empowered to ask whatever you want to ask, and have the knowledge about what's going on.
Yeah. Liz?
Well, I say that trying to find your doctor's a bit like trying to choose your friends. There's some relationships that match, there's some relationships that clash. And on average, I think it's approximately 3 doctors that patients may see when trying to conceive. We've all got our big girl and our big boy pants on. We're able to have difficult decisions discussed, as well as that discussion around seeking a second or sometimes a third opinion, and we can help actually sometimes guide you as well. There are, like, I'm regional, for example, if looking for additional layers of treatment available, I might refer to. So, for example, Jenny, down in Sydney, there are some treatments that aren't available in Queensland, but does every patient need to have that level or that depth of some of the immunotherapies, for example? Perhaps not. And so we can also help guide you towards where to get additional opinion or access additional technologies if they are to be useful. Also, some things that are great and advertised on the internet, on TikToks, and they may not be appropriate for every situation. So we can help as well in those situations with where to go. We're not just going to get a mate to see you to send you back again. That's just not how it works. We really want our patients to fall pregnant. We really, really do. It is a matter of our life's work to help people conceive. So, if you can let us help you along the way, that we'd love to be, able to assist in that matter as well.
The other funny thing is too that sometimes people or they fall pregnant, like they come to their first appointment and they're like, oh, I'm pregnant, and they're almost apologetic. It's like, no, that's great. Like, we don't have to do anything.
Amazing.
Very happy.
Great when you're not needed. It's awesome.
Exactly.
We're going to finish up with one final question, because our Women's Health Week has a theme called Take the Lead. So what would you recommend to patients when they're coming for their first fertility specialist appointment to do or prep or whatever to get the most out of that appointment with you guys? What would be your number one thing for them to think about before they get in the room? Go in reverse. We'll go back to Liz.
I'm happy if people want to write things down, actually, so write down fertility diaries, which include when their periods were, how often they've been sexually active, a summary of fertility treatments to date, medications, questions, things that they've come across on the internet, because sometimes people just can say, does this work? And I'm like, no. It's okay to have the shopping list. We don't necessarily think that's a bad thing. It's great to have in your own quiet and considered time, some, ability to construct and really make sure that you feel that you are able to, under that, sometimes under the pressure of seeing a specialist, we ask a lot of personal questions. Who else is going to ask you so many questions about your sex life? There's some very detailed questions that can be quite intimidating. Maybe not intimidating, but they can really make a person vulnerable. So having had that moment to write some things down is a great idea.
Amazing. Jenny?
I think I'm going to recap on what I said before. One thing would be when am I ready to start doing something? Because some people are just gathering information, maybe just doing baseline investigations, but what is their time frame? When are they going to say, now I draw a line in the sand, I'm ready to start doing something? And the second thing would be to have an idea about how interventional you actually want to be. Some people don't want to do IVF. Some people don't want to have a laparoscopy. I would just ask to listen to what the options are and to be open-minded. I always say if something doesn't work, you always got to come back to the drawing board and say, we need to go in a different direction. Whatever we're doing hasn't worked. Let's try something else. Be open-minded.
Yeah. Fiona?
Yeah, so I would add to both what Liz and Jenny has said. So I love the patient who comes in with a notebook, where they have all their history already there, they've got their results with them, and they've got that list of questions, because really it's going to be a half-hour appointment in a day full of half-hour appointments for us. But for those patients, that is the most important half hour of their day. So you want to be getting everything you possibly can out of that appointment, because that half hour is everything that you've been building up for on your, when you booked this appointment a month ago. And the other thing to add to Jenny, when, contemplating what you want to get out of this appointment, is also having a discussion, if you have a partner, with your partner about what you envisage your family to be, because that's a really important discussion we have as well. If you are coming and haven't yet had a child, what size family do you envisage having in the future in a perfect world? Because that's also going to guide us as to what treatment we would recommend to you. If you are only planning on having one child and that's actually your perfect family, that's really important for us to know, versus, do you know what, you're envisaging the soccer team, and amazingly, if we could have 6 kids, we'd love that. So that's a really important kind of discussion to have had as a couple or as an individual thinking about what you would like, because that's an important part of the history we need to know.
Yeah. And Prue?
Look, yeah, I agree with what everyone has said in terms of, coming, and you want to come with some knowledge, but also not, Google doctor or ChatGPT doctor too much, because obviously, you're coming to see a specialist who has a lot of experience. So I guess, making sure that you're getting your information from the correct sources. I think the main thing is just coming in with some hope and trying. I think there is just, like, it is just so important to state of mind is just so important in fertility, and if we could bottle that and give it out, positivity out to people, you just really, it's quite amazing how you do see that does sometimes play an impact on someone's success. And just that reassurance that, if they have a team around them that they can have hope, and they can, sometimes you see patients' shoulders like literally drop in their, in your consultation, where they sort of say, okay, this is no longer just my problem or our problem, and now we've got someone else who's thinking about our issues and how to help. So I think that's really important as well.
Amazing. Someone has put in, which is absolutely lovely. They just said, I'd like to thank the panelists for their insightful and informative responses. They love being part of this session. So thanks for organising it. So thank you to whoever sent that through. That's divine. So look, I think unfortunately that's all we've got time for tonight, and I'm so sorry if we didn't get to all of the questions that were sent through. It's really important for us that you get the information that you need, and maybe you didn't feel comfortable putting through a question in a forum like this. You'd much prefer to ask it, as we said, in the consult room, and you've filled your notebook with all the things you want to ask. So if your questions haven't been answered, we do have a complimentary phone chat with one of our experienced fertility nurses. So you can scan this QR code and you can book that, and they will just give you a call and you can talk through some of the questions with them. And of course, you can obviously as well always come and see one of our extraordinary fertility specialists, especially the ones who have been on the panel with me tonight. But thank you very much to Fiona, Liz, Jenny and Prue for their time and all of their amazing answers. And thanks to everyone who gave up their Tuesday night to dial in, and enjoy the rest of Women's Health Week, everyone. Good night.
Thanks, Dee.
Thank you.
Bye. Bye.